Hi everyone, this is the second part of epidemiology. Here, the first thing is epidemiological study designs. That depends on the research question and hypothesis, and the resources and time availability, type of outcome of interest, type of exposure of interest, and ethical issues. For example, if you want to do a study like to check the incidence of dental caries, you can't do a cross-sectional study. You have to do a longitudinal study. So our research question is incidence of dental caries. So our study design depends on the research question. That's what in the first line, the research question and hypothesis. Then the resources. If I have very less resource and if I want to find out what is the prevalence of the disease, then I have to go for cross-sectional studies. And if I have very short time, then cross-sectional study. And the outcome, my outcome is incidence of disease. So incidence will definitely take time. So I have to go for cohort study. So like that, our study design depends on our hypothesis and resources, outcome, like this, and ethics. Epidemiological study designs. It includes the research question, the measures and data quality, time, study population, inclusion, exclusion criteria. So these all things will change the study designs. So these are the factors upon which we will decide which study design we have to select. Epidemiological study designs have three major types, and it also have some other types, but here we are going to discuss very few. Like descriptive studies seeks to measure the frequency of disease and or collect descriptive data on risk factors. For example, description: what is the age, gender, place, and economic status, education. Like this, only description we are collecting in this. So by collecting description, we are not able to generate any association or causation, something like that. So we have to go further. So that can be done by analytical studies, where we can test our causal hypothesis about etiology of disease. But in descriptive, we can describe an hypothesis or we can formulate an hypothesis. But to check that hypothesis, we have to go for analytical studies. And experimental, that is RCT, not root canal treatment. It's randomized control trial. So you have to remember this is a randomized control trial. So the same thing, the observation studies, here descriptive studies and analytical studies. These are observational studies. Here in the analytical study, we have four types: ecological, cross-sectional, case control, cohort or follow-up. In the experimental, we have randomized control trial and field trials and community trials. Coming to descriptive study design, these are the steps of descriptive. First is defining the population to be studied. In any study, you have to define the study population. For example, if you want to study the Tadika, you have to define, I am taking this many number of Tadikas in this geographical area, and specific everything you have to specify. What is the study population? Then defining the disease under study. You have to specify the disease. For example, if you are studying dental caries, you can't include some white patches, like some white opacity on the teeth due to enamel abnormalities or developmental disturbance. So that you have to exclude. You have to tell the characteristics of dental caries. So you have to describe the define the disease. Then describe the disease by time, place, person. So this is only description. Then measure of disease, then comparing with known indices. For example, dental caries, you are going to measurement you will do with the indices, and the same indices you can keep and compare with other population. Then formulation of etiological hypothesis. So uses of descriptive design is provide data regarding the magnitude of disease load and types of disease problems in the community in terms of morbidity and mortality rates and ratios. provide clues to disease etiology and help in formulation of an etiology, that is existence of possible causal association between factor and disease is usually recognized in descriptive studies. Provide background data for planning, organizing and evaluating preventive and curative services. They contribute to research by describing variations in disease occurring by time, place and person. Coming to analytical study, it is of four types, but here I have put three types. Ecological is something different, so that I have not put it here. So the first is cross-sectional. Here, if you take two terms, exposure and outcome. So here in the cross-sectional, both exposure and outcomes are at the same time we can measure. But in case control, already outcome is there and we are going for to check the exposure. That's why it's a case to control. Already case is there, outcome is there, and we are going to check, going back to check what is the etiology or what is the risk factor. Cohort study, first is exposure, then is outcome. So this is the difference, main difference between these three type of study designs. So depending on your hypothesis and your time and all. Coming to cross-sectional studies, measures existing disease and current exposure levels at one point in time. Sample without knowledge of exposure or disease. Example, prevalence studies. When you go and check dental caries in Tadika during your camps, that is cross-sectional. So you will tell this many people are DK. For example, out of 40 kids, 21 are having mean DMFT of 3. So that is a prevalence. So cross-sectional studies, advantage and disadvantages. The advantage is often early study design in a line of investigation. Good for hypothesis generation. Relatively easy, quick and inexpensive. Examine multiple exposure or outcomes. Estimate prevalence of disease and exposures. But it is have an equivalent disadvantages, like cannot infer causality. Causality means you can't identify the association, whether dental caries is caused by the sugar intake or improper oral hygiene, we can't tell. Then prevalent versus incidence, that is a disadvantage. May miss latent diseases and may be subjected to recall bias, because if you are giving questionnaire and asking, people might forget and answer something which is totally biased. Then coming to case control studies, identify individual with existing disease and retrospectively measure the exposure. Exposed, non-exposed, exposed, non-exposed, cases, controls, population. Here we are going back. I have already told you, outcome is there. We are going to check the exposure. How? Population you have to take, you have to distribute cases, controls. Then under cases, exposed and not exposed. Under controls, exposed and not exposed. But what case control study will give in the end? That you have to, that is your assignment. I have not put, I think, in the further slides. I will tell you the hint. Either it may give relative risk or odds ratio. That's up to you. Which one you will give, what you have to, that I think I will give for assignment. Case control study. Advantages are good design for rare chronic and long latency diseases. Relatively inexpensive. Allows for examination of multiple exposure. Estimate odds ratio. Hospital-based studies and outbreaks. Disadvantages: multiple outcomes cannot be studied. Recall bias, sampling bias, cannot calculate prevalence and incidence, population relative risk or attributable risk, beware of reverse causation. So these are some of the disadvantages of case control study. Coming to cohort study. Here exposure is here, outcome is here. We are going in this direction. So population exposed, disease, no disease. Population unexposed, disease, no disease. And in the cohort study, we have two types: prospective cohort and retrospective cohort. This is prospective cohort. Study starts and exposure, then disease will be there. In the same time, exposure, study starts, disease. Both are prospective only. I am repeating again. Study starts, exposures happen, then disease. Or exposed already, then we start the study, then it definitely will lead to disease. So both this type are prospective cohort only. Coming to retrospective, here exposure, disease, then disease study starts. So actually you will be have confusion. Then what is case control and what is retrospective cohort? So that is the assignment. What is the difference between retrospective cohort and case control? If you are not able to find out, then you come back to me and I will clarify your doubts. If I tell everything, you will never read the books. So please, you have to read the books. In case if you have doubt, you please come and contact me. Cohort studies. Measure population based incidence, that is the advantage. Relate to risk and risk ratio estimation. Rare exposures. Temporality. Less likely to subject to biases. Possible to assess multiple exposures and outcomes. Disadvantage: impractical for rare disease and disease with long latency, and it is expensive, often large study population, and time of follow-up will be more. And biases like design, in the design, sampling bias, uncertainty, and observer bias. Then study population have non-response, migration, last to follow. Coming to randomized control trial. The basic steps in conducting a randomized control trial is drawing a protocol. That's most important. Then selecting reference and experimental population. Then randomization, manipulation or intervention, then follow-up, then assessment of outcome. So these are the steps: select suitable population, select suitable sample, make necessary exclusion, like inclusion and exclusion. This is not eligible, those who do not wish to give consent. So necessary exclusion you have to do. Then you have to allocate randomly into experimental group and control group. Then manipulation and follow-up, then assessment. So if you ask what is randomized control trial, you have to write this flow chart and with the explanation. Randomized control trials have its own advantage, like least subject to biases of all study. So this is most accepted study design, but it is also having some disadvantages like intent to treat, last to follow up, randomization issues. Not all exposure can be treatments that are assignable. So these are some of the disadvantages. Causation in epidemiology and association and causation. The principal aim of epidemiology is to assess the cause of disease. However, since most epidemiological studies are by natural observational rather than experimental, a number of possible explanations for an observed association need to be considered before we can infer a cause-effect relationship exists. That is, the observed association may in fact be due to the effects of one or more of the following, like chance or bias or confounding. For example, in the beginning, we don't know how dental caries is caused. Some of them are telling it is due to microbes. Some of them are telling it's due to improper oral hygiene. But dental caries was there. So what might be the cause? So chance of improper oral hygiene or That is due to microbes. That is bias. We don't know. Maybe microbes or other factors are there. Are confounding. Like uh, all the kids have that school have carries. Like that some extra factors. So these are the things which if you clarify, then only we can define what is association and causation. The term association and relationship are often used interchangeably. That means both meanings are same. Association may be defined as the occurrence of two variables more often than would be expected by chance. Association does not necessarily imply a causal relationship. This is very important. Association does not necessarily imply a causal relationship. That means if there is association, it does not mean that that is the cause. Cause may be different. So how to check? That I will explain you in the next slide. It will be useful to consider here the concept of correlation. Correlation indicates the degree of association between two characteristics. That correlation coefficient range extends between -1 to +1 or -1.0 to +1.0. Association can be broadly grouped under the three headings like spurious association, indirect association, and direct association. Coming to spurious association, here observed association between the disease and suspected factors may not be real. The best example is previously there are like home delivery, like pregnant women who will deliver. So the death rate of home delivered people are high, that we don't know, but spuriously used to think. But there is no proof whether death rate is high or low. The indirect association. Endemic goiter is generally found in high altitudes, but the cause for endemic goiter is due to iodine deficiency. But we think those who are living in high altitudes have endemic goiter. So that is indirect association because confounding factor. Then direct association. Here, according to this model, the factor A is present, the disease B is also present. And conversely, if B is there, then A will also be there. The above model shows that one-to-one causal relation was necessary and sufficient for the occurrence of disease. But most accepted is direct association, but there will be indirect and spurious association. Additional criteria for judging the causality, like in the absence of controlled experimental evidence to incriminate the cause, certain additional criteria have been evolved for deciding when an association may be considered a causal association. First is temporal association, strength of association, specificity of the association, consistency of the association, biological plausibility, biological gradient, coherence of the association, and experiment. I will explain you what are these. Coming to temporal association, exposure must precede outcome. That means periodontitis. There should be a calculus, there should be a block, and we can expect periodontitis. Strength of association. According to Hill, is a scientist, the stronger the association between the risk factor and outcome, the more likely relationship is to be causal. That means there should be a plaque, there should be a calculus, definitely there will be periodontitis. That is the strength. And specificity of the association. There must be one-to-one relationship between the cause and outcome. Definitely. When the calculus is there, definitely bacterial accumulation, then the immunity response, then the attached gingiva and all the cells will be having response from the bacteria. So loss of attachment will be there, then periodontitis. Consistency of association. A same finding must be observed among different population in different study designs. Yes, periodontitis same. in the different population. Maybe severity will be changed, but the path is same. Biological plausibility. Presence of potential biological mechanism. Yes, here our immunity plays or the action of bacteria. Biological mechanism. Then biological gradient. Change in disease rate should follow from corresponding changes in exposure. That is dose response. For example, if you have for this one Russell periodontal index, if it is 4 different, if it is 5 different, so one we can still have good prognosis. 2, but 4 and 5 already tooth is mobile, we have to extract like that. Then coherence of association. Does the relationship agree with the current knowledge of the natural history biology of the disease? Then the experiment. Does the removal of exposure alter the frequency of the outcome? Yeah, once we remove the plaque, there will be generation of healthy gingiva or production. So these are the things. Once all these things are going according to proper way, then you can tell that is the cause for periodontitis or any disease. So you have to check all these factors to check to give a causal relationship. Uses of epidemiology. Assessing the community's health, like what are the actual and potential health problems in the community and where are they occurring, which population are at increased risk, which problem have declined over time, which one are increasing or have the potential to increase, how do this pattern relate to the level and distribution of public health services available. So these are uses of epidemiology. More like making individual decisions. Many individuals may not realize that they are epidemiologic information to make daily decision affecting their health. When persons decide to quit smoking, climb the stairs rather than wait for elevator, eat a salad rather than a cheeseburger with the fries for lunch, they may be influenced consciously or unconsciously by epidemiologist assessment of risk. So once they know the risk factors, the individual can make individual decisions on their health. Completing the clinical picture. Previously, we thought only bacteria is responsible for caries. After that, we came to know that sugar is responsible. After that, we came to know there should be minimum exposure. So, like that, how you came to know? Epidemiologist only they told. So, when investigating disease outbreak, epidemiologists rely on healthcare providers and laboratorians to establish the proper diagnosis of individual patients. But epidemiologists also contribute to physicians' understanding of the clinical picture and natural history of disease. Recently, epidemiologists, clinicians, and researchers around the world have collaborated to characterize SARS, disease caused by new type of coronavirus that emerged in China in late 2002. Epidemiology has also been instrumental in characterizing many non-acute diseases, such as numerous conditions associated with cigarette smoking, from pulmonary heart disease and lip, throat, and lung cancer. Searching for the causes. Much epidemiological research is devoted to searching for causal factors that influence one's risk of disease. Ideally, the goal is to identify the cause so that appropriate public health action might be taken. One can argue that epidemiology can never prove a causal relationship between an exposure and disease, since much of epidemiology is based on the ecological reasoning. Nevertheless, epidemiology often provides enough information to support effective action. Yes. See, we have taken booster doses of COVID vaccine and we are using face mask. But still, we will get COVID. How? Nobody knows. Even epidemiologists don't know. That means we have missed something. We don't know what is that, which is spreading. Maybe we think that COVID patient has touched that door, that thing, so that again we have touched, so we got. But no proof. You are following all the protocol, still you are having like you have chance to affect with the COVID. So we have to search the cause. I hope you understood. Thank you.